Hello everyone, this is Sunitha, IBCLC Undergrad Study Medic. Today we are going to discuss the topic Infant Concerns While Breastfeeding. So, thought for the day is education is the most powerful weapon you can use to change the world. This is a great quote said by the Nelson Mandela. While speaking about the breastfeeding is the dyadic interaction between the mother and baby. So if any of these both disturbed, it will end up with disruption in compromised milk transfer, growth, hydration, and maternal supply also will get affected. So as a skilled IBCLC should have assessed their if baby any neurological, behavioral, or any anatomical functional variability of the newborn. At the same time, we need to assess the maternal factors also. If you identify everything early, we can prevent the complication associated with this one. So, example, excessive weight loss, jaundice, hypoglycemia, and early weaning. So we can see what are the common infant feeding concerns. Overall we can see. First one is ineffective milk transfer, poor latch and shallow latch, weak or uncoordinated suck, tongue tie and other structural variations, high palate, oral cavity restriction, sleepy and low stamina feeding patterns, premature related feeding immaturity, jaundice, hypoglycemia, GERD, CMPA, and behavioral difficulties like refusal or distractibility. So maybe we cannot cover all the topics, which of the some of the important topics we can cover here. The first one we can focus on ineffective milk transfer. So ineffective milk transfer refers to inadequate removal of milk from the breast due to infant, maternal and dyadic factors. It results in reduced intake for the infant and insufficient stimulation of the maternal milk production. So what are the causes for this one? If the baby is latch shallow or weak uncoordinated short sucking burst, it's especially in the preterm babies, and if the baby has minimal swallowing and prolonged very frequent feeds. Usually the baby has to finish the feeding between 20 to 30 minutes, but if taking more than that, so that means the baby not getting enough milk, that means the baby latch is shallow. So then a clicking sound, when there is a clicking sound, there is a lack of vacuum, then we can hear the clicking sounds where the baby is sucking. Then infant fatigue during feeding. The same, if the baby is taking long time for feeding, then the baby will get fatigue. So even the sucking also, baby needs energy, right? So when the baby taking long time, the baby will weight also get lost. So poor weight gain also will be there. So even after feeding also, the baby still persistently showing the hunger cues. That means the baby not received enough milk for the baby. What are the common causes for this? Oral structural issues, especially tongue tie, high palate, micrognanthia. It's a micrognanthia, we can say Robin-Berry syndrome, and low stamina, especially if the baby born less than 37 weeks, and if the baby has jaundice, hypoglycemia. This all will cause low stamina for the baby. Then poor positioning. When the baby is not positioned properly, not held near to the mother, or baby doesn't open the mouth fully. If that is, we can address like improper latch and positioning. Then maternal low supply or delayed lactogenesis. So if the mother has any additional risk factors, then there's a possibility of delayed lactogenesis too. That also will cause maternal low supply. The neuromuscular immaturity and hypotonia, especially in Down syndrome, other neuromuscular diseases, the baby will have less milk transfer. Then what will this less milk transfer, what will cause? Because of this, baby will take inadequate intake and baby will have dehydration, excessive weight loss. The bilirubin will not be clear from the body because still the baby is not passing adequate stool. Then decline in maternal milk supply. If there is a output only, there's a milk coming in, right? So the maternal supply also will go down because improper emptying of the breast that will send the negative feedback mechanism to the brain. Then early breastfeeding cessation. This all will lead to when if the baby is not sucking properly, the mother will breast will get engorged. It may lead to mastitis. There's a possibility of early cessation of breastfeeding. So how we can manage? So whatever the situation, first we need to assess the latch and positioning. So for once we need to come, if found out there's a latch is not good or the position is not good, we can correct that one. Then if that preterm baby, we can do breast compression to enhance the flow. So that the baby will get more milk inside the mouth. And increase feeding frequency. We can ask the mother how frequently she is feeding. We can tell them to feed at least minimum 8 to 12 times in a day. We need to feed the baby. So if the baby is not taking milk properly, we can tell the mother to pump the milk to feed the baby. Then if there is any underlying factors like the infant, any tongue tie that can be corrected, or any maternal factors that also to be addressed. So how we can do this, follow whether the baby got adequate milk or not. We can educate the mother, like how many stools has to be passed day, second day, third day, how many urine has to be passed. Then whether baby daily when we are checking the weight, we can know whether baby has increased weight or still the baby is losing weight. Based on this, we can assess the milk transfer. So next one is tongue tie. Tongue tie is a congenital condition in which lingual frenulum is short, tight and restrictively attached. So what this will cause limiting normal tongue mobility. So because effective breastfeeding requires infant to elevate, extend, cup, lateralize the tongue. Any restriction can impair latch, seal and milk transfer. If you see this picture, there is the lingual frenulum looks very thick, and when you see the tongue tip also, it is heart shaped. That means it's tethered. So baby cannot elevate the tongue as much as possible to create vacuum for the baby while sucking. So then what will cause when the baby is sucking, because of the tongue tie, the mother develop nipple pain trauma. After end of the feeding, mother we can assess the lipstick shaped nipples. Then infant also will not have effective milk transfer. We can get clicking sound because lack of vacuum. When we many times if you're latching also, baby will get sliding off from the breast. Now, so this all will lead to potential poor weight gain. So here also we need to correct the positioning and latch to maximize the tongue function. So we can try foot for hold or laid back positioning. Whichever position the baby is latching properly, we can check, and we can encourage the mother to do breast compression to support the milk transfer. So next we can tell the mother to pump the milk when the milk is not transferred properly. Then we need to check the we can check pre and post breastfeeding weight check, so that we can ensure how much milk baby took from the breast. Then we need to refer the baby, because we cannot diagnose. We can tell our assessment to pediatrician, and we can refer the baby to do ENT for frenotomy. This because even if the tongue tie, it should be diagnosed by the pediatrician. So after this also, the skilled lactation support is very needed to establish the breastfeeding relationship. Next one is high palate. This high or narrow palate structural variation where the hard palate is elevated and steeply arched. It's maybe congenital, or the baby is staying in NICU for a long time. The baby had endotracheal tube, OGT. So this all will lead to higher palate, because if the palate is high, the some area the tongue reaches while breastfeeding. The surface area will be get reduced when the baby is breastfeeding. So because the effective milk transfer depends on the tongue ability to elevate, curve, and create negative pressure. If the palate is too high, the tongue cannot reach until that high. That will impact the milk transfer. Then what is the functional impacts we can see? We can see that difficulty in achieving deep latch and poor tongue and palate seal that will cause clicking and milk leakage, and there will be reduced negative pressure because the palate is too far, and weak milk transfer. So this all same like the tongue tight will lead to nipple compression and maternal pain. So because of this, baby also get fatigue because inefficient milk transfer. The baby also will take long time for feeding. So here we can try the technique. Super latch, we can aim the nipple toward the junction of the hard and soft palate, because whenever the baby is sucking, the nipple should be reach at the soft junction of the soft and hard palate, right? Then only we can achieve proper latch. So we need to do that manually so that the maximum milk transfer will be there, and we can teach the mother how to support the mandible and cheek to perform dancer hold. So the seal will be maintained throughout the feeding, and we can encourage the mother to try sideline or laid back position so that maximum breast tissue will be naturally filled the palatal. From the gravity, the baby will get more milk. Next one is torticollis. Torticollis is the condition where infant has persistent head tilt and rotation due to tightness or imbalance of the neck muscle, most commonly sternocleidomastoid muscle. If the baby has short the muscle at right side, we can cause right torticollis, but the baby head will be tilted to right side. The baby looks towards the left side. Then right torticollis. It might be congenital, or it can be occurred also, because when sometime the baby is lying, or when caregiver is approaching long time in the right side, there's a possibility of developing right side torticollis. So if you see it in this picture, for the baby with right torticollis, right ear is tilted towards the right shoulder because there is shortening of the right SCM muscle, but the baby faces rotates to the left side. Then in left torticollis, the same, left ear tilted towards the left shoulder because then face rotates to the right. So the tightness leads to range of motion, strength, and gross motor issues. So when it will happen, it will also can lead to flattening of the back one side of the head. So if you notice like this, we need to inform to the doctor, and we need to schedule for the physiotherapist also. So this is the physiology. Shortens SCM pulls the mastoid down. The tight SCM contracts and shortens, pulling the mastoid process downward, and head tilt towards the right side. The tight side, the same, right? Then the same muscle rotates the head away. The same muscle is responsible for the head rotation. So the SCM also attached to the sternum and clavicle. When it contracts, that rotates the head towards the opposite side. So the chin naturally points away from the tight SCM. The opposite SCM becomes overstretched. The SCM on the non-tight side becomes lengthened and weaker, reinforces the rotation pattern. So pathophysiology, I already showed shortening of the SCM muscle, lift cervical rotation. The infant will be arcing, crying, pulling specifically on the one breath, because if the baby has one side torticollis, the baby will look if right side, and the baby will look comfortable with left side looking. So but baby will reject the other breast because it's difficult to turn the head towards the other side. Then asymmetrical jaw excursion. In here, SCM tension with the master causing tilt to the temporomandibular joint. Because that inability to, we cannot, usually for the good latch, the baby has to open wide and we should attain the asymmetrical latch, right? But because of the diagonal gap, its inability to achieve symmetrical wide latch. So baby will have will refuse the breast also. Next one is mechanical nipple trauma. Because the mandibular reaching to compensated for restricted neck rotation creates shearing forces. So the extension will be restricted. The baby will not get that much wide latch. So unilateral wedge-shaped erosion and fissure may develop, because we can assess the nipple after feeding. We can assess like lipstick shaped or compressed nipple we can notice. Then vacuum instability. Hypertonicity prevents the circumferential seal leading to aerobagium. So because of lack of vacuum, we can hear the audible clicking sounds during swallow phase, excessive gastric distress or colic, because there will be a more air swallow will be there. The fifth one is pseudoangloglacia. What's the physiology behind this? Is myofascial tension radiates to the hyoid bone, restricting posterior tongue elevation. So because of that, reduced tongue lift that improves only when head is neutral alignment. That's why we are recommending to put football position, so that baby will maintain the neutral position for breastfeeding. To see the management of baby with torticollis, we can use football clutch hold, especially the affected side. When we are feeding, we can try this position, so the baby cervical will be maintained in the neutral position. Then biological nurturing, so we can give light back positioning, so the baby neck will be extended, the space will be extended, because while giving one side only, the gravity is associated with hypertonicity will increase, so we can break that one. Then dancer hold, we can support the mandible and cheek while feeding, so to facilitate the deeper latch. So we can directly aim the nipple towards the junction of the soft and hard palate, so that we can achieve the asymmetrical wide mouth opening, also achieve the optimal latch also. Then we need to involve the multidisciplinary team approach, so we can involve pediatric physiotherapist and osteopathic manipulator treatment also we can aim, so that the baby condition also will improve. The next one is prematurity and infant feeding concerns. So prematurity means when the baby born before 37 weeks. So especially the baby will have immature neurological, respiratory, gastrointestinal, oral motor system. So which directly affect the ability to breastfeed effectively. So the feeding challenges arise from the underdeveloped coordination, low stamina, and structural immaturity. Why here cup feeding? Because preterm babies, the cup feeding is better to way of feeding, because because baby will not get adequate milk transfer when we are giving breastfeeding, so we can top up with cup feeding. So what are the challenges will be here? First one is immature suck-swallow breathing coordination. So what's the reason for this? Incomplete myelination of the cranial nerves affecting the suck-swallow breathing coordination. So usually within 1 or 2 sucks the baby will have swallowing, but here the baby will have 3 to 5 sucks followed by long respiratory pauses or coughing and choking. So that means still the baby underdeveloped with the suck-swallow breathing coordination. Next one is low orofacial muscle tone. This is hypotonia of the masseter or buccinator muscle, prevents a sustained vacuum. That's why when we are assessing the baby, we can say dimpling while the baby is sucking. Because that's why we cannot predict the baby is taking milk or not. Because full-term baby, when the milk milk is inside, the baby cheeks will be full. But here, even the baby sucking, if the milk is there also, the baby cheeks will be dimpled. So, because of that inadequate fat and support tissue, it will cause frequent slipping of the breast. So, baby will not sustain the latch at the breast. So, and we can see them audible clicking sounds, unable to maintain the deep latch. Then limited glycogen stores. Because of the reduced brown fat and hepatic glycogen leads to rapid hypoglycemia if the baby feeding is insufficient. And sleepy baby syndrome, the baby, because if the baby has hypoglycemia, even though the preterm baby, is very difficult to wake up the baby for the feeding. That's why we need to remove the blankets, we need to change the diaper before the feeding, so that all the things will make the baby to wake up. And we need to inform the mother how to wake up the baby during feeding. We can need to touch the ear, play around the ear, so the baby will and while giving cup feeding also, we need to encourage the mother to keep away from the body, so the sleepiness of the baby will be reduced. Next will be state regulation deficit. Because of the immature central nervous system, the baby will have easy sensory overload. What will happen? Suddenly the baby will from the awake and fussy state to fall into sleep, and baby will not when we are trying to interact also, the baby will turn the head and baby will not get into that action, so baby will not constantly look into that action. This all the because and then fingers playing. This is if the baby finishes feeding only, they usually will have the fingers playing, right? But here the behavior we cannot predict in this preterm babies. Next one is increased metabolic demand. The caloric cost of the work of feeding may exceed the actual milk intake. So because the baby is spending more time and more energy on feeding, so whatever the feeding the baby is getting, that is less beneficial than the baby's sucking time. The baby is taking more sucking time. So what will happen? The baby will have weight loss. If so, there is a significant weight loss, more than 10% of weight loss. And that also, if the preterm babies, the weight should get return to normal birth weight within 14 to 15 days. But here, if the baby is not doing so, the baby will not get back to birth weight. What are the management we can do here? So we can encourage the mother to breastfeed first. Then we can encourage the mother to before breastfeeding, tell her to express the EBM so that she can top up with EBM with cup feeding. Then she need to maintain her supply by pumping. So I tell her to pump after every session, because there will be a emptying of the breast will be less compared to term baby. Then support orofacial tone. Here also we can suggest the dancer hold, and we can do if we are giving feeding, we can give we no need to give full stretch at one time. We can give some time pass, then we can latch, so the baby also will not get that much tired. Supplementary nursing system. When the baby is at breast itself, we can give the EBM, like even it's by NGT also fine. So what will happen, that when the baby suck, we are giving feeding, that will be act as a reward for the baby. Then maintain neuro stability. So if the baby is not good and at breast also, we can tell the mother to put kangaroo care. So it will increase the heart rate, thermoregulation and glucose levels. So it encourages the instinctive feeding behaviors. Next infant feeding concern is jaundice. Jaundice occurs when unconjugated bilirubin accumulates because of the newborn liver is immature and cannot efficiently process the excrete bilirubin. This leads to visibly yellowing and typically appearing first on the face, progressively downwards. That's why we are calling it cephalocaudal. So if you are seeing the first first will be only the head, next will be head and abdomen. The third stage below the umbilicus up to the knees, then it will be below the knees, then the full part. This is the grading. So that's why when we are checking, we need to check. If you're checking with the TCB machine, they will check first on the head. So so when the starting stage itself, we can identify. So what are the reasons for this one? First one is starvation jaundice. When the baby doesn't receive adequate milk transfer, it will decrease the peristalsis, and that will increase the enterohepatic circulation. That means even the conjugated bilirubin will get unconjugated at the intestine. It's again get back into the bloodstream of the baby. So because the baby is not getting adequate feed, how we can predict that one baby will have weight loss more than 10% and infrequent dark stools even after crossing the 4 days, that still the baby is passing meconium draining stools. That all the indicators of poor milk transfer. Because of that only baby is developing jaundice. The second one is delayed meconium passages. So meconium passage, this one, meconium contain 1 mg of bilirubin per gram. So when there is less milk transfer, the meconium passage also will be get delayed. So the bilirubin excretion also will be get stuck. So baby will have jaundice. Next one is breast milk jaundice. It's a late onset benign condition caused by factors in the milk that increase intestinal bilirubin absorption. A thriving weight gaining infant with persistent LOE. It will peak at 2 weeks of life, then it slowly decline. Next one is ineffective stimulus, because this one poor milk transfer result in lower oxytocin and prolactin cycle. So this all because of the low milk transfer. So that will lead to even reduce the stooling frequency. When there is a reduced stooling frequency, the building of a bilirubin inside the body will be high. So when we are assessing the suck of the baby, we need to assess whether it is 1:1. For one suck, if there is one swallowing, there is a good transfer. If the 5 suck only, if the one transfer means one swallow means the baby is not getting adequate milk from the mother, either because of the improper latch or it's because of the maternal conditions. So what are the goal here? Enhance the bilirubin excretion. So we need to increase the mother to give 10 to 12 times feedings because the colostrum will act as the laxative effect. So the baby will pass the meconium easily. The quality of the milk transfer, we can weigh the baby pre and post feed. So we can assure the baby how much milk the baby taken, and optimize breast emptying. So we can increase the mother to the breast compression during feeding. So the baby will get high lipid milk. Then caloric and fluid bridge. So if the milk transfer is inadequate, we can inform the mother to express the EBM. Or either so we can give supplemental nursing system to avoid further dehydration or reabsorption of bilirubin back. Then phototherapy support. So in phototherapy support also, we need to improvise with a Billy blanket. So the baby remains skin to skin with the mother. No need to unnecessarily switch off the phototherapy for the feeding. The baby can continue the breastfeeding relationship while on phototherapy. Next one is hypoglycemia. This one we can commonly see in many times in even the wards and NICU. Neonatal hypoglycemia metabolic condition where newborn blood glucose levels falls below the minimum needed support the normal brain function. It's because of the preterm, the baby will have limited glycogen stores and immature glucose regulation and increase the metabolic demand. The 1:1 rule is, according to the human lactation book, if the infant is not achieving 1:1 sexual ratio at least for 10 to 15 minutes, so the calorie intake is insufficient to maintain euglycemia. So we should, while as IBCLC, it's very important to assess the milk transfer, how much milk the baby is taking, like by assessing the suck and swallow. So what's the how we can do it? How we can increase the blood glucose of the baby? Metabolic conservation. We can offer the skin to skin for the baby. So what will do? It will reduce the caloric expenditure for thermoregulation, because it will be maintained by the mother body, and so it will stabilizes the glucose. Then direct calorie bridge, we can inform the mother to express the colostrum. So if the latch is ineffective, we can give EBM, and then mucosal glucose source, 40% oral glucose gel we can administer. It will rise the blood glucose immediately. Usually we are applying the buccal absorption, the root of buccal. So in that period, if the glucose is within reach normal, there is no need for unnecessary IV cannulation. Next one is glycemic maintenance. So we need to feed the baby 8 to 12 times in 24 hours. So small and frequent boluses prevent the peaks and valleys in the blood sugar. Then nutritional support. So if the mother doesn't have milk, it's better to give donor breast milk rather than going for formula milk. Next one is reflux. What is reflux? Reflux is the backward flow of stomach contents into the esophagus due to immature lower esophageal sphincter. Especially for the preterm babies, the sphincter will be a little bit loose compared to the term babies. So how we can manage? We can manage with upright positioning and frequent burping after the feeding or in between the feeding. Avoid overfeeding, because if we are giving overfeeding, it will stretch the stomach. So again, it will open the sphincter. It automatically the milk flow back from the stomach to the esophagus. So medical treatment is only needed when if the reflux is causing pain or poor growth or complications. Next one is oral thrush. Oral thrush is a fungal infection in the infant mouth caused by the Candida albicans, leading to white adherent patches on the tongue, gums, and inner cheeks. It occurs when the baby normal oral flora is disturbed, allowing yeast to overgrow in the warm, moist environment. Especially if the mother is or has mastitis, or mother received any antibiotics, there's a possibility of develop oral thrush for the baby. So here what we as IBCLC, we need to ensure effective latch, whether the baby has adequately transferred the milk, and we need to make sure the mother will not get any pain during the latch. So that position we are offering also, we need to ask the mother whether she has any pain like that. Then we need to offer frequent feeds to maintain intake. Some infant feed less due to oral soreness, because if something in the mouth paining, the baby will take less milk, right? So we need to be frequently feed, and we need to sterilize if pacifier is offered, we need to sterilize, and bottle, if bottle, better to give cup feeding, but bottles, everything should be sterilized properly, even the pumping parts, and we need to inform the mother, do hand hygiene, and we can limit the visitors also. Then if the baby is getting infection, the mother also should be treated with antifungal. So because it again cross infection, the baby gets, the mother also will get, the baby also will get. During that period, we can support the mother for pumping, because because of the oral sore, the baby may not empty the breast properly. So we can inform the mother to do pumping after the feeding, so she can secure her milk supply. The next one is respiratory distress. Here, respiratory distress is the difficulty in breathing due to impaired oxygenation or ventilation. The baby will have tachypneic more than 60 breaths per minute, nasal flaring, grinding, chest retraction, sinus and perfusion. If you see the feeding concern of this one, so here we need to involve the pediatrician whether it can be offered breastfeeding, because if the baby condition is stable, okay, breastfeeding, or better to go with OGT feeding of EBM, so until the baby condition is stabilizes. Next one is cardiac stress. Here is compromised heart function leading to poor circulation, oxygen delivery. Here baby might have tachycardic or bradycardic, poor pulses, delayed capillary refill. It's maybe more than 2 to 3 seconds, and pallor or mottling, hepatomegaly, feeding intolerance, sweating and with feeds. Here also we can support with the small and frequent feeds, and we need to check what type of cardiac condition. So any cyanotic spells, everything we need to check. And so here also no need to force the baby for long feeding. Better to integrate the pediatrician, offer the NGT feeding by EBM. At the same time, we need to encourage the mother to pump to maintain the milk supply. Because this condition, the baby infant cannot maintain coordinate with the solo breathing, the baby will fatigue easily. So there's a possibility of weak latch and poor transfer, early stopping of the feeding. So that's why I told it, we need to give paced feeding, shorter session, alternate feeding methods. I hope you learned some infant concerns while breastfeeding or so. It's very important whether first we need to aim for breastfeeding. If not possible, we need to offer with EBM, mother own EBM. So at the same time, we need to educate the mother how to maintain the milk supply. It's very important because baby condition stabilize after some time. So at that time, the mother have adequate milk to support the baby. So all the medical and developmental issues limit the infant ability to suck, coordinate infant sustained feeding. So it's very essential to understand the clinical indicators of this jaundice, hypoglycemia and prematurity oral thrush, so that we can address the issue to the appropriate designators, pediatrician, and we can involve the multidisciplinary approach into our care, so that the breastfeeding relationship of the diet will be continued. Okay, we'll go for some MCQ. First one is, which infant behavior most strongly indicates pathological reflex rather than the normal happy spitting? These are the options. First one is occasional hiccups after large feeding. Second, spitting up small amounts of milk without distress. Third one, preferring to be held upright for few minutes after feed. Persistent back arcing, coughing during feeds, and poor weight gain. Which one? The answer is D. This back arcing, poor weight gain. This back arcing is we can call it a Sandifer syndrome. It's a very red flag. So if the baby has very pain because of GERD, the baby will exhibit this symptom. The second one is the late preterm infant is often called the great pretender in lactation because the first one, they have very strong suck but don't actually swallow. The second, they look like full-term babies but lack the neurological stamina to feed effectively. They mimic hunger cues even when they are full. They rarely experience jaundice, hypoglycemia compared to full-term. So they have very strong suck but don't actually swallow, or which one? Second one, they look big but tire easily, may sleep throughout the feedings. That's why they will take the feeding more than 30 minutes, and the milk transfer is not that much as much they spending the calories. Third one is the infant is the 4 days old. The mother reports she's very sleepy, difficult to wake for feeds, observe orange brick dust crystals in the diaper. What is the most likely clinical significance? The first option is a normal physiological transition of newborn kidneys, evidence of high-fat milk intake, a red flag for significant dehydration, insufficient intake. The fourth one is a common reaction to the maternal prenatal vitamins. What's the answer? A red flag for dehydration, because it's already 4 days. In this period, if the baby has this one, the baby is not receiving adequate milk transfer. That is the one. So if it is past 1 or 2 days, it's acceptable, because still the baby is having lactogenesis 2 is not started. But here, if it is still there, there is a urate crystal, that should be referred to the pediatrician, and we need to check for the milk transfer. The fourth one is a 6-day-old infant born 37 weeks, presents with a 12% weight loss from the birth. The mother reports the infant latches sucks for 40 minutes but never seems to satisfied. Upon observation, the infant has frequent swallow sucks with very few audible swallows. The mother has significant nipple trauma. Digital palpation reveals high arc palate and a Coriolis type 3 restriction. What is the priority clinical intervention? So, refer immediately for phrenotomy to address the type 3 restriction. Instruct the mother to use nipple shoe to protect her damaged tissue. Develop a triple feeding plan to ensure infant calorie intake while protecting the supply. Advise the mother to switch to exclusive pumping until nipple trauma heals. Option is C. Because in the presence of 12% weight loss, the priority is always feed the baby. So, here type 3 anatomy high palate contributing factors. So we need to give the breastfeeding after the top of the DBF. Then we need to inform the mother to pump. So why we cannot give the nipple shield? Because with the underlying factors not corrected means still the baby will not get adequate milk. So correcting underlying factors also very important. So before that, at the meantime, what we can do? Can do with triple feeding. Then next we can refer the baby to pediatrician, or so that they can manage with tongue-tie release. The fifth one is a 34-week late preterm infant being assessed on day 3 of life. The infant appears alert but has disorganized suck swallow pattern, often taking 3 to 4 sucks before single swallow is heard. The infant has 9% birth weight and currently under phototherapy for hyperbole. What is the most likely physiological explanation for the feeding difficulty? It's a late preterm 34-week. The option A is the infant has structural defect like cleft palate but was missed at birth. Infant experiencing pretender syndrome where neurological immaturity, low stamina, poor coordination. The infant showing signs of CMPA triggered by maternal diet. Infant building level too low to trigger the rooting reflex. So here option is B. Because the baby is taking 3 to 4 sucks for per swallowing means the baby is acting fast, but the milk is getting is less, and baby is spending lot of energy. So, but the baby is not receiving that much calorie in the breast milk what the baby is sucking. So, here answer is answer B. Because this babies looks like full-term babies but have significant neurological immaturity. This leads to disorganized sucking, rapid fatigue, and high risk of falling off the curve due to the insufficient milk transfer. Okay, thank you so much for listening.